Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, managing editor and host, and this is part of our new series covering the novel coronavirus or COVID-19. Now, as healthcare providers, we're motivated to share experiences from the front line, and during this series, we're going to be talking from providers all over the globe about their experience with this virus. Now, joining us, as usual, is our editor-in-chief, Monty Mythen. Hello, Monty.
Hey, Desiree, how are you?
I'm doing pretty well, just getting more interested in what we can do to help share the experiences of providers around the globe. What's your experience been so far?
Well, a lot of preparation here in London, in the UK, a lot of big changes in the last week or so, and all of those preparations are really accelerating now. From a personal perspective, we're all healthy at the moment. We're trying to live life as normal. We're trying to do a reasonable degree of distancing, and there's quite a lot of respective self-isolation going on from people who are being a little bit unwell. But broadly speaking, life is normal. Yeah,
that's similar to here in the U.S., I think. But we definitely want to start talking to others about what their experiences are, like I said before. And joining us today, we have a friend of the Top Med Talk family, actually, one of our repeat guests, Professor Michael Scott, who is now at the University of Pennsylvania. Mike, thanks for joining us.
Hi, good afternoon, Desiree and Monty.
So, Mike, for our listeners, I know that you've told us before where you have been practicing here in the States, but I think things have changed recently. So update us on what's happening with you.
Yes, I was in Virginia for 3.5 years. I've just moved up to University of Pennsylvania, one of the division chief jobs in anesthesia and critical care, just starting this year. So I find myself in an interesting position. We've basically thrust into what is now developing as a pandemic across the world. And so we've had an interesting first few weeks in preparing for how we're going to deal with the wave of patients we are expecting.
Yeah, I'm sure that is on the front of everyone's mind, especially in our world of anesthesia and critical care. Can you tell us a little bit about what you're doing to prepare for the influx of patients? I guess the first question is, have you started to see more cases of coronavirus in Pennsylvania and in your community?
Yes, I think the situation in the US is slightly different because we have not got widespread testing like there is in Europe and back in the UK and Italy. So the actual number is not really known at the moment, but we have had positive cases out in the community in schools. We have started taking positive patients at the hospital. And so there has been an escalation strategy here to reduce movement and socially isolate people. So schools are closing or closed. Montgomery County was announced as to reduce traffic and basically try and reduce movement. And there's been a very good response. Our own hospital, University of Pennsylvania, they are promoting remote working, as well as obviously escalating the strategy necessary to cope with the proposed influx of patients.
So, Mike, I know that one of your colleagues is going to join us today. Can you tell us? Can you introduce him for us?
Yeah. So, we obviously have a wealth of talent across both medical anesthesia and neurocritical care at Penn. One of my colleagues in the anesthesia department is called Maurizio, who is from Italy and trained in Milan, but he's now full-time here at Penn. He's an expert in ARDS, and with his contacts in Milan, he has really given us very useful insight in how to prepare our overall strategy and particularly horizontal strategy for intensive care admissions. And he has kindly agreed to join today, and some of his previous colleagues are as well.
Okay, before we talk to Maurizio, Monty, did you want to chime in?
Yeah, Mike, in this series that we're running at the moment, where it's very much clinician to clinician, most of us are anesthesia critical care providers, but we also have a very, very broad global audience. So ARDS is every day of the week abbreviation for us, but not for everybody.
Correct. So it's effectively saying that people have extremely severe lung injury and can't get enough oxygen into the body and enough carbon dioxide out, which is the main function of the lungs. So people need to be ventilated with the mechanical ventilator. So, and this is one of the key things of COVID-19, and one of the key things that we need to address. It's the commonest life-threatening condition.
So, Maurizio, thank you for joining us.
Hi, how are you doing?
Oh, we're doing well. I appreciate you and Mike both taking the time out to chat with us on Top Med Talk about COVID-19 and your experiences on the front line. Can you give us a little bit? I know Mike did a great job of introducing you, but can you tell us a little bit more about your background?
Yeah, so I'm from Milan. I went to medical school at the University of Milan. I then finished my residency there. I was actually an assistant professor there for about 3 years. I went to the United States came to the United States in 1999 for personal reasons, which is my wife. And I repeated my residency, I trained, and I've been at the University of Pennsylvania since 2003, first as a fellow and then as a faculty. My specific interest of academic research is ARDS, which is what Mike very nicely described.
And ARDS, sorry to interrupt you, Maurizio. ARDS, yes. Acute respiratory distress.
Distress syndrome, exactly. Acute respiratory distress syndrome. And I do research in this field. It's pretty much the passion of my life, if you can say that. I kept my relationships with my old department and my old friends, and of course, as soon as this started, I contacted them, and I have been witnessing this escalation of this disaster, this humanitarian disaster, since the beginning. If you do not talk to people over there directly, if you just watch the news or read the journals, you don't really get a sense of the vastity, of the immensity of the tsunami of disease that's coming upon us. And this is why I felt the urge since, I would say, 2 weeks ago, of telling everybody how serious this thing is and how much we need to prepare. And I feel like I'm a Cassandra who is, knows about the Trojan horse and is screaming around, get ready. And I think now people are getting that this is serious. I just want to make sure that people understand how serious it is. The reason I also invited Mirko to this conversation is because my friend Mirko and Andrea will tell you what happens when the healthcare system fails. This is a situation that is not totally apparent, again, just looking at the news or reading journal articles. I really want them to say this because I want people to understand why it is so important to be prepared. As some of my Italian friends say, this is not just a pneumonia, this is not H1N1, where there are some sick patients and we'll be able to take care of them and still continue to do our usual job. This is the equivalent of biological warfare, essentially, because it's a wave of patients that keeps coming and keeps coming.
So Maurizio, Monty here coming back in. So from the perspective in London, I hope we've listened to our colleagues in Italy, and as opposed to our previous experiences with influenza or H1N1 or all the alternative viruses that have come through, we are preparing ourselves for very, very considerable numbers of patients requiring mechanical ventilation quite soon. Is there any chance that we might be panicking and over-preparing from your perspective? I know we'll talk to your colleagues in Italy in a second.
I don't think so. I don't see any good reason why we should, in the UK or in the USA, we should do better. We should be in a better situation. I really don't think so. Let me put it like this: the focus that we have so far in the Western world, the focus on dealing with this disease, has always been on hospital care, especially on ICU care. So people are wondering how many ventilators we can have, how many ICU beds we can have, how many we can dedicate, how many we can open. I think that Mirko and Andrea's point is slightly different. They want to make the point that we will not be able to fight this disease unless we work on the ground, on the territory. Try to keep patients away from hospitals. Try to keep patients from flooding, preventing the patients from flooding hospitals. Try to not overwhelm the healthcare system, which in certain parts of Italy is now pretty much incapable to take care of anything else but COVID. We're talking about labor and delivery services, about regular surgeries. It's becoming more and more difficult. And they will tell you much better than I can do. They will tell you that the attention has to be on the ground, on the territory. Try to keep patients at home, managing patients at home, not just the ones with few symptoms, but even more severely symptoms. They can breathe. If they don't need a ventilator, they should stay at home. And I think this is a very unique perspective that is not coming through. It's not coming through the media. It's not coming through the medical journals.
Thank you, Maurizio. Well, we have another colleague from Italy joining us. We have Andrea Ciocca from Naples, correct, Andrea?
That's right.
Yeah. So give us a little bit about your background. Where are you from, and what role are you playing in the COVID-19 pandemic?
I am originally from Bergamo, which is currently the hotspot of the epidemic in Italy. By education, I'm an engineer in telecommunication. But then after working in the informatics, in the IT field, I joined an NGO, and then I spent 10 years working as an aid worker in different countries, mostly in Africa and Asia, in medical emergencies. So I dealt with a few contagious epidemics. That's why I will try to bring my experience and see to bring some ideas on how non-medical measures can help face this big problem.
Tell us a little bit about what you are seeing on the ground where you are, or the communications that you have had with Bergamo.
The situation in Bergamo is critical. I've been talking a lot with Mirko, who is in the frontline, as well as other medical colleagues and friends that I know. But most of all, I'm in touch with my family, my parents, and friends and relatives who are still living there. Many of them are sick now at different degrees. I try, by being far away in Naples, which is some 800 kilometers south of Lombardy, the situation is not as difficult as it is in Lombardy. I think we are 1 or 2 weeks late than they are in Bergamo right now, meaning that the peak of the epidemics is expected to arrive here in the next future. I can assume that the situation that we are living here is a little bit what you will face in the US or in other countries in the next days or weeks, which means we are scared because we are looking at what is happening over there. And on one hand, the authorities are telling us that the situation is under control, and the only problem is that we need more beds in the hospital, in the ICU in the hospital. But then when I talk to people, my feeling is a little bit different. And if I look at the situation from my point of view, what we have is a new disease for which we don't have a cure and we don't have a vaccine. What we know about it, even if we don't have a full epidemiologic profile of the disease, we know that the fatality rate is low, so it's not so lethal, but it's very contagious. It's probably going to be global, which means that we're going to fight this disease in every type of setting that goes from like low, scarcely populated environments to big cities and towns where like people are living on top of each other. To me, this sounds like the perfect exam for a public health course exam, meaning that yes, you need the medical perspective, but you also you need all the help that you can have from those people who are not medical, logistics, technical, and the authorities have to make very important decisions.
Andrea, Monty Mythen here, from London, England, could I interrupt for a second? And to clarify, your friends and family in Bergamo, as I understand, is it that most households now have people who are sick with, flu-like symptoms, but managing at home at the moment? Is it such that it's unusual for people to be well or to have stayed well? That's
one problem that we have now is we don't know who is sick and who is not, meaning that very, very few people are tested. A lot of people are home, maybe with a mild fever, a little bit of cough. We can assume most of these people are positive to the COVID virus already, which is, for instance, what happens in a malaria outbreak. When you have a malaria outbreak, you stop testing people. If they have a fever, you just assume they're positive and you give them treatment. And that now, with the situation as it is in the hospitals, and I'm not only referring to the fact that they are overcrowded, but also that probably most of the hospitals are infected already. So the worst thing that could happen is to go to a hospital for a test and then be infected by the virus. What I'm telling to my brother who has kids at home is, okay, just be careful. You don't want kids to have a cut or something, and then you have to go to the emergency room for something which is not related to the virus because you might be infected over there. This is the level of the situation, and I don't want to be paranoid, but that's the situation. We have family doctors who are running up and down. Of course, they are trying to manage far too many patients that can physically do. They are running around like crazy. I was talking to a friend who was waiting for a doctor, and the doctor said, I'm sorry, I'm going to be a little bit late because I was visiting the patient before you, and I decided to refer this patient to the hospital. No ambulance was available, so I had to go to drive the patient with my own car. I mean, this is absolutely crazy. This cannot happen. This doesn't happen in an Ebola outbreak. This doesn't happen in a measles outbreak. This should not happen in Europe in 2020.
From your experience in your as a humanitarian aid worker and previous outbreaks, what are you suggesting that those in your own area there in Naples, as you said that you probably are a little bit further behind, what are you suggesting that the system there starts doing? And what do you know? Are you involved in any of that?
Yeah, of course. I try to understand, first of all, what kind of preparation they're doing. And again, they are preparing hospitals and ICUs to receive severe patients, which is good, but it's only a part of the approach that must be taken.
Yeah, from that logistical standpoint, you were saying that, just as you described that, physicians are driving patients to the hospital. What are you doing, or what do you think the community is doing there to prepare for those types of situations?
What they're doing, or what they should be doing?
Well, maybe a little bit of both. I mean, that you know of. I mean, that you're privy to. I guess what you think is going on.
Let's say that I would be happy if the authorities, the health authorities and the political authorities would be trying to prepare some measures to release the pressure from the hospital, because the pressure will come and it will be not sustainable. First of all, what I know and I'm happy about is that they are trying to prepare some hospitals which will be 100% dedicated to the virus, to the COVID virus. So this big mistake that was made in the beginning to try to manage this problem and keep other wards up and running at the same time in the same facility was a big mistake, and I hope this will not be made in Naples and in the other regions in Italy. Then I really think they try to push care to the homes of the patients as much as possible. First of all, a good idea to release the pressure from the hospitals, but also to avoid further infections. But how you do it? Again, I go to the experience that I have when I call back home. I have some friends who are going from pharmacy to pharmacy, try to get an oximeter and try to get some oxygen bottles to bring home to their parents. I think it should not be so complicated to have a public system to supply continuously people who are at home, and they don't need to be hospitalized, but they can manage the situation up to the point where indications are clear that these people need to be hospitalized, and to try to keep them at home as much as possible. Also because at home, probably there's someone who can take care of them, while if they go to an overcrowded ICU, they will just be lying on the bed with very tired and frustrated medicals, try to do whatever they can, and they will not be able to stand up and go for a little walk and have a chat like they do at home. Like now, families are informed from doctors that they never met that the relative is dead, and without a constant and continuous information about how the sickness is evolving.
So, Andrea, you've mentioned something there which I haven't heard in discussion so far in the United Kingdom. It sounds as though you're suggesting that it might be appropriate to go back to the fever, what we used to call in London, the fever hospital idea. So way back in the day when we had outbreaks of smallpox or cholera, institutions were opened to direct patients there and to cluster the care of those patients who are unwell with an infectious disease. Is that what you're proposing might happen?
Absolutely. I wish so. So what happens when, for instance, when you work in a refugee camp, this is my direct experience from Bangladesh 2 years ago. So we had massive influx of refugees from Burma, and you have a million of people living on top of each other. And you know that over there, every rainy season, you have a big risk of cholera. So what do? First of all, you prepare some areas where you can isolate patients from who you might have in 1 or 2 or 3 years for cholera. And all these patients should go there, and none of those patients should go to the other medical facilities that you already prepared inside or just outside the camp. That happened when we had an unexpected diphtheria outbreak at the time. It took some time to understand that it was diphtheria because those are not so common. And we found out that these people were not vaccinated back in Burma. So we had to decide which of the general hospitals that we had should remain general hospitals or clinics, and which one should be converted to manage only diphtheria. From my perspective, there's no way around this. This is how it's supposed to be. What I hear is also that some hotels are being converted to facility for the COVID infection. I think it's a step in the right direction.
Andrea, one question I had, in China, they were building the pop-up hospitals within, days. Is that something, as far as infrastructure goes, that Italy has started to do or is contemplating doing? Do you know?
I have not heard of any initiative like that. I think they're mainly trying to switch existing facilities to become COVID-only clinics, but not building new hospitals from scratch, as far as I've heard.
Mike, to bring you into the conversation again, so is that something that you guys are working on in the U.S.?
I think what's important is we learn from other countries' experience. And I think how Maurizio and I have approached this is what we do as a hospital system for the first few patients can have a downstream impact on our ability to cope with the problem, but also how appropriately to escalate it and also maintain staffing levels. Cohorting patients from the outset is probably a key in containing the disease. You can take the hospital view of having COVID hospitals, but I think in the US we're going to see patients arrive at the ED. So what's important is we cohort these within the hospital system appropriately, and particularly on ICUs as well. I think every hospital will have their limited number of negative pressure beds, which will soon get saturated. So this could be key in how we actually manage to cope with this disease.
Mike, you and Maurizio may be able to speak to this. The discussion now is whether or not to continue elective cases, because that is freeing up beds, freeing up space within the facilities, as well as trying to not, spread the virus further with patients that traditionally are seen in elective cases, as far as, people over the age of 75, those that are higher risk. Are you guys, what are you preparing for there in the guise of the operating room?
We have a very centralized strategy, which has been very organized and stepped up appropriately, dealing with everything from exposure. We're running scenarios, having the PPE correct for everyone, from the actual de-escalation. So the strategy to release critical care beds, obviously, one of the ways is to stop operating on elective patients. So they've already agreed on their stepped strategy on how to release beds, who shouldn't come in for elective surgery, and who we would move horizontally. And you're right, because that's all vital in how we cope with the rising numbers of patients that need critical care.
As it is happening in my old hospital where I come from, the operating rooms have turned into ICU rooms. There are patients on ventilators in the operating rooms receiving critical care services by intensivists and by intensivists and sometimes by also non-ICU providers, because whoever is available needs to help. So this is a scenario for which we have to be prepared. Once our ICU capability is exhausted, we need to think about creative and innovative forms to take care of patients in other locations. One is the operating room, which is actually relatively easy. The other one is the regular floors, managing patients receiving some type of respiratory assistance on regular floors. Another aspect that they have been dealing with in Milan and in the region was to have a system for non-critical care trained physicians taking care of these patients. For example, they have a system where other specialists are delivering care under supervision by an anesthetist or by an ICU doctor. These are things that we need to think about in this country also and do it fast. Train non-ICU providers, designing structures, team structures, and things like this.
Yeah, Maurizio and Mike, but there in Italy, we know that they've been hit particularly hard in the region, and there's speculation of whether or not it's an age-related or how it's been spread. But do you think, from your perspective and your knowledge of how things have been going there in the region of Italy, that we should expect things to move in the same direction here in the U.S., spread as quickly, have as many critically ill patients as they are seeing there?
I don't know. I expect so. I can think of many reasons why we should be different. The healthcare system in Italy is a developed system. They don't have as many ICU beds as we do, but at the same time, the surge of patients will overwhelm any healthcare system. There are some social factors that may be in our favor. For example, most of the country in the United States is more dispersed, especially in the Midwest, and in areas where houses are separated from each other, people don't live in condominiums. But in New York, Philadelphia, San Francisco, well, we're not very different by the point of view. There are also some other factors, some other social factors. There is a more centralized system in Europe, in Italy, in England. There is a healthcare system that can actually assign hospitals to different roles and functions. Here in the United States, it is not like this exactly. There are big city hospitals, university hospitals with huge facilities, but there's not much regional coordination. Two hospitals in the same city may not know what the other hospital is doing. And I see that as very problematic.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.